if you modify the result, ESR for a complete modular ESR. That is the important for the next solution complete modular. Actually, is the number and also the age. Age is the factor. तो age को match करें तो कुछ लगता है ना तो generally क्या है? For menopause in Indian country, like starting from 45 to 55. It is the standard in Indian. It is depend on so many factors. You know that in European countries or in America or UK, in these countries the menopause occurs after why? Because the menopause depends on the nutritional status of a female. यदि ऐसा female higher than nutritional status लो करके menopause not after. But if unmarried mother, the menopause occurs getting before 45. So it depends on your so nutritional status. And you know there is so many taboo for like starting to college but normal menstruation count शुरू कर मेरा भी शुरू हुआ after age of 10 11 but the penalty is offer early menopause is also offer early but it's a false step. Nothing depends on the parent. Second child, a child, someone from Japanese there is a mother having for more child have a menopause offers early, but it is also a false because it is not dependent on the parent. How many child they are having. Also not depend on some depend on socio-economic status, but mostly not depend on socio-economic status. But there is some depend on like the smoking cause the menopause early. So smoking is an important factor. These are the factors that depend on the menopause. Now, what is the pathophysiological changes occurs in age? In the menstruation, what happens? We know that firstly the corpuscle is developed, and ultimately the ovulation occurs, and after the progesterone takes the upper hand. These are big influences. What happens in postmenopausal women is the corpus luteum is not developed properly in postmenopausal. And menopause it is not like patient comes with at for last 12 months. It is not like that. Before the menstruation, there is a 1 or 2 years of irregular age, and patient complain that our periods are like 6 months interval, like 8 months interval. So there is a clear sign for the menopause ultimate of. There is 1 or 2 years of that menstruation is also. So starting menopause. এমন ভাবে তুমি যেন চিন্তা করছো বন্ধ হয়ে যাবে তখন অন্য ব্যাপার কি হতে পারে ধর ভালো এন্ডোমেট্রিয়াম আপনার এন্ডোমেট্রিয়াল ক্যান্সার এখানে কি হবে অল্প অল্প করে প্রতি মাসে ভিডিও ক্যান্সার কি হলো আর মিলি হলো তারপর এই বছর হলো তারপর বছর হলো আলাদা এসে যদি বলতে যে না আমার লাস্ট বছর ধরে ডিজিটাল প্রোগ্রামটা চালানো হচ্ছে পুরোটা কখনো 8 মাস কখনো হচ্ছে তো তখন চিন্তা করতে হবে রাইট না এরকম নিয়ে আমরা আপনার so before you know the normal frequency alpha frequency হচ্ছে তারপর তো প্রজেস্টেরন আসছে প্রজেস্টেরন তো কি করছে সেটিং করছে সেই প্রজেস্টেরন এই মেনোপজে কি হয় তো এই alpha frequencyটা তৈরি হয় তো এখানে and ovulatory ovulation is very good আর কি হয় আর হচ্ছে তো জানি যে প্রথম থেকে কোলেস্টেরল সিচুয়েশন হয় না এবং আলটিমেট যত গেমসটা ইডিয়া মানে টেস্টোস্টেরন ইডিয়া তখন কি হয় ইস্ট্রোজেনের পরিমাণ কমে তো যখন কমে কোলেস্টেরল দেশ তখন ইস্ট্রোজেন তাহলে আমরা যখন পরীক্ষা করে দেয় যখন এরোপ্লেন করেছিলাম উপরে কি ছিল জিএনএ সেখান থেকে নিচে কি আসছিল এপিসি হচ্ছিল আমাদের তৈরি কি ইস্ট্রোজেন তাহলে এখন যদি ইস্ট্রোজেন ফিডব্যাক মেকানিজম কি হবে ইনক্রিজ এপিসি তো পরীক্ষাটা যদি এখন নাও পরীক্ষার সময় দেখলে যেমন তোরা নিট দিবি তখন প্রশ্ন আছে যে ovarian failure what is the diagnosis point of your body এখানে কিন্তু করতে হবে that increase is the indicator of ovarian failure তাহলে ওর মধ্যে কি হবে এটা কি হাই থাকে আর কি হতে পারে আর তো যেগুলো কি হরমোনগুলো সেই হরমোন যেগুলো আছে যে so these hormones are secreted in the kidney. They kidney. এবারে হচ্ছে তো ক্যারিডিয়াক ট্রিটমেন্ট করলে অফ এক্সট্রোজেন এন্ড প্রোজেস্টেরন এবারে প্রোজেস্ট পেশেন্ট কি কমপ্লেইন করতে আসে এই কমপ্লেইন করতে আসে যে প্রথম যে কমপ্লেইন হবে সেটা হচ্ছে হট ফ্লাশ वो करने में बहुत से हुआ ना ऐसा estrogen secretion are increased that is a vasodilation in the face and in the neck so that is a rushes of blood and as a rushes of blood occur that was the hot flashes so hot flash में हमारे arterial এই হট ফ্লাশের জন্য কি হবে তাদের ইনক্রিজ ওয়েটিং হবে পেশেন্ট কি করে আপনি স্ট্যান্ড করছে আমি বসে আছি তাও বন্ধ হচ্ছে না তো দ্যাট ইজ ইনক্রিজ অ্যামাউন্ট অফ ওয়েটিং আর কি হবে আর তো পেশেন্ট যারা ফ্রম নিউরোসাইকিয়াট্রিক্যাল প্রবলেম তো দ্যাট ইজ very in puberty and development that is a massive changes in the hormone so that is in puberty also that is a psychological problem in the development also as the situation of that is a some neurological problem so কি বলে হবে রাতে ঘুমাবে না তার জন্য একটা সাইকোলজিক্যাল প্রবলেম হবে so there is a psychological problem negative problem is there আর কি হবে artificial কি হবে as the estrogen secretion falls there is a androgen electron they become dry so there is called the androgen electron আর কি প্রবলেম হবে আর প্রবলেম হবে তো there is a form there is a effect on libido guidance of that, mood problem, mood swings of moods. So, some patients, the libido may decrease. But in some cases, as the fear of pregnancy become down, so there may be a chance of increased libido in some people. Correct? Students say libido where because the chance of fear of pregnancy are limited. So there fear of pregnancy. As you take প্রথম যে বললাম যে প্রথম প্রেগন্যান্সি যখন মেরুদণ্ড হচ্ছে তার আগে রেজিস্টার কি হয় 4 মাস সমান এটা সবসময় একটা ভয় এই মনে আমার প্রেগন্যান্সি আর কিছু করে দিল তো দ্যাট ইয়ার fear of pregnancy are increased in before the menopause are and one most important is that there is a down at the release of estrogen in the body, so there is a massive osteoporosis. So pregnancy most so menopause woman in Indian scenario there is 100% chance of not osteoporosis. So আমরা যখন যারা যদি অর্থোপেডিক প্র্যাকটিস করেন হ্যাঁ তারা দুটো তিনটে করে ক্যালকুলেশন তো what Indian scenario for osteoporosis occurs. So osteoporosis কিভাবে ডায়াগনোসিস করি by X-ray scan. X-ray scan থেকে আমরা osteoporosis ডায়াগনোসিস X-ray মানে একটা ভ্যালু থাকে এই ভ্যালু যদি মাইনাস 2.5 এর নিচে থাকে then it is a chance of মানে পেশেন্ট মাথায় গলা osteoporosis. Then you have to supplement with the calcium. বাকি তোকে এর বিন্দু আছে আর তোর আর ডায়াগনোসিস আমি কি বলি যে এটা কোর্স সেটা মেনোপজ একটা হচ্ছে তোর ইনক্রিজ অফ ইনক্রিজ আরেকটা হচ্ছে E2 minus E1 level. E1 is pure or is so level. Because the availability in menopause woman is more than 1. In postmenopause it is less than 1. So by E2 E1 effectively and also you know the estrogen and progesterone. Estrogen and progesterone है हमारा तो ये मैनेजमेंट भी हो रहा है मैनेजमेंट से start from your the hot flashes your the medicine so many medicines are available right so hot flashes जो है ऐसा এটা আমরা নরমাল করতে পারি অথবা তো আইসোট এবং বলে পাওয়া যায় এখানে তৈরি করে সেগুলো এই হট ফ্লাশেসগুলো পাওয়া যায় আর কি করতে হবে ব্যাকটা হতে পারে তো কম হচ্ছে না তো যেটা অ্যান্টিবায়োটিক ক্যালসিয়াম তো বলি দিলাম ম্যালেরিয়া যেগুলো অ্যান্টিবায়োটিক মানে ম্যালেরিয়া যেগুলো ড্রাই হয়ে যায় তার জন্য মানে ক্রিম পাওয়া যায় So it is the important to know that menopause is really a psychological code. So menopause also physical concept and also a psychological you have to constantly be adequate. There are just so many things offered. Over with 45 to 55, there is because after students are not offered, and there is some problem with health issues. So you have to treat it adequately. Okay. So this is the one prospect of menopause. So performance for depression, for the factor will increase. What is the factor of depression? What are the hormonal changes or what we can define it or the result that is actual menopause. So basic level, EB1 level, and the progesterone level, and also you can measure the evening gonadotropin. In post-menopausal women, the gonadotropin hormone expression higher evening increase annually. So evening gonadotropin we can measure. These are the tests are available for the menopause. Now, start looking at symptoms. Increased sweating, increased irritability, insomnia, osteoporosis, anxiety, all these are the symptoms of menopause. Okay, so symptoms what causes are so sweating cannot because that's what understand in the face and in the face. So there is a rushes of blood and that was the and the hot substance. Okay. And so really hot flash generally you are প্রথম বেশ কত হওয়ার 1 বছরের মধ্যে 1 বছর বেরিয়ে গেলে আর অনেকটা কমছে। এই প্রথম বছর একটু ওষুধ দিয়ে রাখবো। এটা বলে রাখবো মাথা বড় ওষুধ দিয়ে রাখবো। Next হচ্ছে তোর দেখবেন তো আমরা জানি যে মানে একটা যে কি আছে না তো ওটা ভালো করে তো এগুলো জানতে হবে মানে পরীক্ষা পাস করে ঠিক আছে বলো হচ্ছে তো বেসিক্যালি আমরা কি মাপি এই রেডিওসিস টেস্টে এই মেজারটা এটা এইচসিটি লেভেল কিন্তু তাই হচ্ছে so first stage is the HM Joseph's test. What is the test? এটা হচ্ছে তো একটা প্রেগনেন্ট মাদার জন্য কি টেস্ট করি ইউনিট টেস্ট বিকজ ইট ইজ নট সোর্স অফ বললাম যে ইউনিটি ডিআইসি তো ডিআইসি ইজ দা সোর্স ঠিক আছে তো আমরা কি করব একটা প্রেগনেন্ট মাদারের ইউনিটি এই ইউনিটটা নিয়ে একটা ইনভেনশন মাইলকে আমরা তোর 3 দিন পর পর আপনার ইনজেকশন বলো একটা প্রেগনেন্ট মহিলা তার ইনজেকশন আমরা নিলাম এর সেটা থেকে 0.5 এমএল করে ইউনিট আপনার মানে ইনজেকশন দিয়ে একটা ইনভেনশন মাইলকে পর পর ইউনিট and fourth day we open the abdomen of this mice. And if we found that the hemorrhagic, okay, hemorrhagic যেটা আমরা কি করি কর্পাস, hemorrhagic কর্পাস যেটা থাকে এটা আমাদের কর্পাস লুটিয়ামের কাউন্টার কর্পাস লুটিয়াম এবং প্রেগন্যান্সি ফ্যাক্টর তো even hemorrhagic কর্পাস যেটা বলা হয় তার একটি পার্ট so we can diagnose that because hemorrhagic কোন হবে ওভারলোড হবে so that way we can diagnose the this disease in okay মানে যদি আমরা ওভুলেশন রোগ হতে পারি বলতে পারি नेक्स्ट হচ্ছে তো ফ্র্যাগমেন্ট টেস্ট কি করতে হবে না এখানে যে বেসিক 10 to 15 মিনিট অফ কিপিং অফ আ প্রেগন্যান্ট লেডি এখানে ধরে নিতে হবে এই কি করতে হবে ওটা আইভি দিতে ইন্ট্রাভেনাস আইভি দিয়ে কোথায় দিবি না ফিমেল র্যাপিড ওকে and he am examining the eradicated ovary, we can examine it 24 and 48 hours. And if there is a ovulation occur in this rabbit, so we can diagnose with the female আগেটা ছিল সপ্তাহ দ্বিতীয়টা হলো আইভি নেক্সট হচ্ছে এডি মাইনাস টেস্ট ঠিক আছে what is this test what is this is the so 5 ml urine 5 ml urine যদি নিতে হবে এই একটা যে টুল টুলের যে লিঙ্ক সেখানে ওকে ইনজেক্ট করতে হবে 5 ml of urine of patient and 1 to 2 hours later the fluid from the जो कोरेट যে ওয়াইটা থাকে সেটা থেকে ফ্লুইডটা ইনজেক্ট and if we are found the any amount of carbon in the fluid then we can diagnose it as the is really pregnant. Basically, এই টেস্টটা হচ্ছে মানে কম কোয়ালিটির টেস্ট এবং এই টেস্টটাই করা হতো আগের যে টেস্ট করা হতো এই টেস্টটা করা হতো বাট এই টেস্টের প্রসেসটা কি আছে প্রসেসটা হচ্ছে যে এই টেস্টটা করাতে এই কয়টা ফিল্ডটা দিতে হবে এই দেখতে হবে যে তোর আগে ওর মধ্যে কোনো মানবতা ছিল না আগে যদি থাকতো ইনজেক্ট করার পর খাবারগুলো ইনজেকশন তো সেজন্য কি হয় না আগে তো ওই ফিল্ডটা ছেড়ে দেখতে হবে ওর মধ্যে কোনো মানবতা আছে যদি খাবারগুলো আছে তো আমি যদি না থাকে তবে যদি ইনজেকশনটা ফাইনালি ইনজেক্ট করবি হিসাবে মানবতা is present so these are the tests and lastly the test is available is the immunological test কি করি এগুলো আমরা করি একটা হচ্ছে পেট কালার টেস্ট এটি কি হয় এটি হচ্ছে বেসিক্যালি অ্যান্টিবডিটা কি করে তৈরি হয় অ্যান্টিবডি তৈরি বলা হচ্ছে র্যাপিডকে আমরা অ্যান্টিজেন দিচ্ছি র্যাপিড ওর এগেইনস্টে অ্যান্টিবডি ওইটা যখন প্রেগন্যান্সি টেস্ট করি এটা হচ্ছে তোর র্যাপিডকে আমরা অ্যান্টিজেন দিয়ে দেয় তার এগেইনস্টে র্যাপিড অ্যান্টিবডি তৈরি করি এবারে সেই অ্যান্টিবডিটা নিয়ে আমরা ওই ছোট একটা থাকে যদি তোর কন্ট্রোল কি হয় কন্ট্রোলে তোর যদি প্রেগন্যান্সি নেগেটিভ থাকে তাহলে কি হবে শুধুমাত্র তোর কন্ট্রোল নাই পর্যন্ত কিছু হবে বেশি কিছু আসবে যদি প্রেগন্যান্সির পরিমাণ কি হয় এই যেটা হয় এটা কিছু হয় হয়ে যায় তো ঠিক তার ये बढ़ते हैं এবং অ্যান্টিবডিটা আমরা কিন্তু ওই র্যাপিডকে নিয়ে আমরা অপারেশন শুরু করি আর অ্যান্টিজেনটা হচ্ছে আমরা এই বিভিন্ন স্যাম্পলের কাছে কথা বলি অ্যান্টিজেন অ্যান্টিবডি ফিক্স that produce a coagulum and these coagulum are responsible for the allergy বলো ওরতে তো র্যাপিড থেকে অ্যান্টিবডি দেওয়া আর অ্যান্টিজেনটা কোনটা হচ্ছে আমাদের ইউনিট তো ইউনিট আমরা কি দিয়ে অ্যান্টিজেন অ্যাক্টিভিটি রিঅ্যাকশন করে কি হচ্ছে যে কর্পোরেশন অফ অ্যান্টিজেন অ্যাক্টিভিটি প্রোডিউস অফ coagulum and these coagulum are responsible for the color changes তখন কি হবে না এটাও পজিটিভ এটাও পজিটিভ and you know that beta HCG infected product is appear as early as 5 years. Transient quantity so taken mother so transient quantity in pregnancy positive for G. Pregnancy সম্পর্কে জানার দরকার হচ্ছে avoid a legal issue. So, not a sound structure, not antibiotic. So, how complex are the practice of the doctor antibiotic? Okay, you always think about the toxicity of the drug. তো যখন কি একটা প্রেগন্যান্ট মাদারকে কোন একটা অ্যান্টিবডি এক্সেপ্ট অ্যামোক্সিসিলিন এগুলো খুব সেফ হ্যাঁ ইন কেসেস অফ আইসোমাইসিন অর অ্যামোক্সিসিলিন এই অ্যান্টিবডি পাওয়া যায় যেগুলো টক্সিন টক্সাইসিন সিস্টোটক্সিন এগুলো খুব ব্যবহার লিওটক্সিন তখনই কিন্তু তোকে সব সময় ব্যাক অফ দ্য মাইন্ডে চিন্তা করতে হবে যে যাকে দিচ্ছি তাকে একবার জিজ্ঞেস করে দিতে হবে এবং সিস্টেমের ট্যাগের উপরে লিখে রাখতে হবে যে তার রিয়েলিটি হবে টু অ্যাভয়েড অ্যাডভান্স সাইড ইফেক্ট ইন নিয়ার ফিউচার তাই না বহু ঘটনা ঘটছে এরকম আমার তো এরকমই হয় এক মাস হয় দু মাস হয় না আমি যদি লিখে দিই পরে দেখা গেল কার তো প্রেগন্যান্সিতে যারা খুবই দরকার এই ধরনের জিনিসকে এই ধরনের উপরে সব সময় একটা রিপোর্টকে নিজের মধ্যে ওকে লিখে রাখতে হবে এই বিএনপি তবে কি একটা তাহলে ওটার কাছে উদাহরণ করেছে এবারে তো ধর তুই তাকে 5 দিন পর এগুলো জাস্ট অনেক ফর প্র্যাকটিক্যাল হবে 5 দিন পর প্রেগন্যান্সিতে পড়ালে প্রেগন্যান্সি দিল তো এটা বুঝে নেওয়ার জন্য কারণ এটা প্রেগন্যান্সি নেই you always have to check after 72 days এইগুলো why substantial যদি 5 দিন পর যারা এইচডি ইউনিট আসে এরও না তো তাকেও যদি সাবস্টেন্স হয় না ও প্রেগন্যান্ট আছে তো ওকে কি করতে হবে ওকে আবার 7 থেকে 10 দিন পর আবার আচ্ছা এই কলেজ আইডার করো বাচ্চা আছে 10 মাসের বাচ্চা 10 মাসের বাচ্চা রাখো খুঁজে হচ্ছে না বলছে না বলবি না হ্যাঁ তো কি হতে দেখিয়েছে মানে সম্পর্ক থেকে তারপর ইংরেজি করে দেখা গেল তো আর আরো কি বলতে our country was previously good. Actually, lactating embryo, absolute lactating embryo was 6 months. Not something so breastfeeding choices. Following the absolute, absolute was 6 months. That's the ধারণা কি এই ব্রেস্টফিড করার পর কি আমার বাচ্চা হবে তো এটা ধারণা ভুল আমরা কি হচ্ছে ফার্স্ট 6 মান্থ হচ্ছে অ্যাবসলিউট তো প্রোটেকশন বাকি 6 মান্থের পর তো সেগুলো সম্পর্কে আর এগুলো সম্পর্কে জানতে হবে যা এই পেশেন্ট এখন কোন বলে আনওয়ান্টেড প্রেগন্যান্সি বা কম বয়সে এগুলো কি তাহলে আমরা কি ওই তো আমরা কি করতে পারি এক নম্বর করতে পারি হচ্ছে এক কালার টেস্ট মানে দেখা কালার চেঞ্জ আরেকটা কি করতে পারি ল্যাটেক্স পার্টিকেল অ্যাপ্লিকেশন টেস্ট আরেকটা কি করতে পারি র্যাপিড টেক্সট টেস্ট all the three tests are in the application all antigen antibody reaction তো কি বলবো আমরা একটা হচ্ছে তো এক কালার টেস্ট এই হচ্ছে ল্যাটেক্স পার্টিকেল অ্যাপ্লিকেশন টেস্ট and third is the rapid text test. All three are the test. And the antigen antibody reaction lead to mutations and color changes in these tests, and these indicate the presence of ACD in the urine and the pregnancy response. So this is the pregnancy test. আমাদের এই পবিত্র পরীক্ষায় নতুন আর কিছু না আবার বলে না সবাই এখন প্র্যাকটিস করে স্যার কি এখন প্র্যাকটিস মাইন্ডে আর যদি একটু গাইড প্র্যাকটিস করে তো বুঝতে পারি তো জেনারেলি এইটা তো সবাই পারবে এইগুলো এটা কোনো চাপ নেই কিন্তু বাকি ওই তিনটে টেস্ট যেটা অ্যাসিড নন টেস্ট Timeline test and validity test এই তিনটে টেস্টের জন্য তোমরা জানতে হবে মানে খুব একটা কমপ্লিকেটেড কিছু না একটা টেকনিক্যালি বুঝতে পারে কত এমএল ইউজ দিবি সেটা হলো পরিকল্পনা প্রমাণ হতে পারে এই বিভিন্ন পরিমাণ কিন্তু বাকি যেটা আছে সেটা হচ্ছে এমন কিছু নয় সেটা হচ্ছে এক মিনিট রেগার্ডিং টেস্ট হয় যদি ফ্লুইড দিয়ে দেখবি যে তো হেমোলিটিক কর্মক্ষমতা ডেভেলপ করছে না করছে যদি হেমোলিটিক কর্মক্ষমতা ডেভেলপ করে দেখবে যদি হেমোলিটিক কর্মক্ষমতা ডেভেলপ না করে নেক্সট যেটা হবে ফ্যাট ব্যান্ডে কি করব আমরা ওই ইউনিটটা ইঞ্জেক্ট করব আইভি ইঞ্জেক্ট করার জন্য আমরা তোর অ্যাবডোমেনাল ইনস্পেক্ট করে দেখব যে তার মধ্যে ওভুলেশন দেখতে না ঠিক আছে এন্ড দিস ইজ রেসপন্স অন দা ফিমেল লেভেল তাহলে প্রথমটা হচ্ছে ইমেচিওর দ্বিতীয়টা ফিমেল তিন নম্বরটা যেটা আছে সেটা হচ্ছে গেলি ম্যানিফেস্টেড male, not female. So আমরা কি দেখি স্পার্মাটো দেওয়া ফিমেল কমানো দেওয়া তো অলিম্পিকাল মেল এর কি করব আমরা ইউনিটটা নিয়ে ওর লিঙ্ক নোডে আমরা পুশ করব পুশ করে কয়েকটাতে স্পিডটা জমবে স্পিডটাকে এডিট করে দেখব যে তার মধ্যে স্পার্মাটো দেওয়া আছে না এই জিনিসটা ইনফরমেশন করা অন বিকজ is before the revolution of pregnancy so এই জিনিসটা কিন্তু আগে করা হচ্ছে কারণ এটা আগে পরিস্থিতি তো এই জিনিসটা জরুরি করে তো see the in for the pregnancy এরকম হলো pregnancy next হচ্ছে সিঙ্গেল অ্যানালিসিস হতে আমি বলেছিলাম কিন্তু এখন আমরা আবার সাথে দেখেছিল যে যেহেতু ইনফেলতে একটা যেতে আছে ডিফাইন এর আসলে ডিফাইন যেটা আছে ডিফাইন এর নিউয়ার একটা ইনফেক্টলি একটা টপিক so by definition what is the image is the product that produced in a male genitalia and is equal হচ্ছে because it is the synchronous action of synchronous action হচ্ছে একটা হচ্ছে the nerve you know the a sympathetic nerve is the only nerve intact sympathetic nerve the ultimate issue that is the production of semen. Because in sympathetic protein that ejaculation cannot occur. Not only sympathetic protein, sympathetic nerve that created ejaculation. So sympathetic nerve is the ultimate intact sympathetic nerve. Ultimate way to provide ejaculation. And if you know that is a complex action কি হচ্ছে তো কি হতে হবে তো এখানে হচ্ছে epididymis heart and you know the accessory যেগুলো আমাদের পড়িয়েছিলাম all these are contraction are required epididymis এর contraction মানে পাঁচটা আছে কি বলি the contraction তাহলে there is a contraction of epididymis heart there is a contraction and also there is a massive blood flow in your two muscles corpus cavernosus and ischio cavernosus right two muscles in the heart so there is a massive vascularization and increased amount of blood flow in this and that causes the involvement of the so there is a two muscle that is the massive so that is the two muscle and also there is the closure of internal urethral valve to prevent the retrograde ejaculation. So you know that a complete synchronized process. So you in the ejaculation if there is any problem in that so ejaculation will go in that sympathetic protein করতে হবে তাহলে ejaculation হচ্ছে তুই যদি কারো ইন্টারনাল স্টিকারটা খোলা থাকে তাহলে কি হবে রেট্রোগ্রেড ejaculation হবে so all these are required so in now come the semen analysis ঠিক আছে কি এর কি হয় মানে semen analysis তো কাকে করা হয় যাদের তো যদি ফার্স্টে কি করা হয় যদি করা হয় তাহলে করা যাবে এই এখন যদি একটা তোর খুব ইয়ে হচ্ছে যদি এখন প্রচুর মানুষ হচ্ছে মানুষ এবছর পুরো এগিয়ে হয়ে যাবে প্রচুর মানুষের খুব কমন কম্পিটিশন হচ্ছে একটি মর্টালিটি কিন্তু বিশিষ্টটা তুলে and infertility is the most common complication of the mom so some issues except in your fertility issue in mom complication হয়েছে তাই রিজলভ করে যাবে সার্জারি হলো তুই তাহলে সিমেন্ট টেস্ট করে দেখতে পারিস এটা প্রেসক্রিপশনটা কাজ করছে না so except fertility issue that you may examine but তুই আর কারো কোনো হাই ট্রমা হয়েছে ঠিক আছে তাহলে করতে পারিস কেউ ধর কোনো ব্লাড ক্যান্সার বা কিছু হয়েছে তাহলে কেউ হচ্ছে তাদের করতে পারিস তো there is so many area where artificial intelligence can done okay and you know these similar analysis করে তাহলে উপরে লেখা আছে extensive কি বলতে বলছো যে to suppose not to ejaculate or that generally আমরা কি করি generally আমরা 2 to 5 সেকেন্ড একটা extend পিরিয়ড রেখে তারপর আমরা করে রাখি বুঝলেন তো মানে এমন নয় যে তুমি ইচ্ছা হলো তাই আগে থেকে অ্যানালাইজ করে সেটা নট সাম প্র্যাকটিস হচ্ছে যে 2 to 5 সেকেন্ড একটা extend পিরিয়ড করতে হবে এই পিরিয়ডটা কিন্তু পুরো ইয়াবলটা হবে after that you perform a serial analysis to unknown result বলো নেক্সট হচ্ছে আপনি পেশেন্টকে পাঠালি যে যাও একটা ক্লিক করে দিন এবারে হচ্ছে ফর নরমাল সিঙ্গেল এফেক্ট কি যে নরমাল কতটা অ্যাবনরমাল নরমাল কাউন্ট কত আমরা বলছিলাম জেনারেলি 40 to 100 মিলিয়ন হচ্ছে কাউন্ট নরমাল তার মধ্যে কি হচ্ছে তার মধ্যে যে ডিপ ওই কোন গুগল যখন সবই अवेलेबल মানে যে দেখি যে আপনারা দেখেন ক্লাস 1 ক্লাস 2 ক্লাস 1 মানে হচ্ছে গুড ফর্ম ক্লাস 1 তো ক্লাস 1 এর গুড ফর্ম কত হতে হবে মোর দ্যান 50% নট তো 40 মিলিয়ন পাউন্ড 50 মিলিয়ন পাউন্ড কিন্তু তার মধ্যে আমার 50% নরমাল নয় তাহলে কিন্তু ওই 50 মিলিয়ন পাউন্ডে কোনো কাজ নেই পাউন্ড কাউন্ট ইন অ্যাবসলিউট ইন্ডিকেটর যে পাউন্ড কাউন্ট থাকতে হবে লোকে 40 থেকে 100 মিলিয়ন বাট তার মধ্যে ওভার 50% নরমাল থাকতে হবে গ্রেড 1 এ থাকতে হবে গ্রেড 1 পাউন্ড ওকে বলতো তো গ্রেড 1 পাউন্ড মোর দ্যান 50% ইজ আ ইন্ডিকেটর ওকে নেক্সট হচ্ছে তো মানে এটা হচ্ছে কোয়ালিটি অফ দ্য স্পার্ম আমাদের স্পার্ম কাউন্ট নেক্সট যেটা করা সেটা হচ্ছে কোয়ালিটি অফ দ্য স্পার্ম নেক্সট হচ্ছে তো অ্যাবনরমাল স্পার্মের কাউন্ট কম থাকতে হবে এবারে হচ্ছে 20 মিলিয়ন 40 মিলিয়ন থেকে 20 হাফ করে যাবে 20 মিলিয়নের পার্সেন্ট নিচে থাকলে there is a chance of infertility. Well, 40 million, 100 million, 20 million. 20 million indicator that's the infertility. The master is 20 to 40. 20 in between 20 to 40 million, there is a 50% chance of infertility. Well, Opportunity of a sound is 30 to 100 million sound. Sound is with sound initially when আমি ফাটাই ইনফাটাই নয় সেটা কোনো ব্যাপার না ওটা তখন এটা হবে পার্মানেন্ট কোয়ালিটি গ্রেড 1 সাউন্ড যদি মোর দ্যান 50% বেশি হয় then it is a good sperm. But if grade 1 less than 50%, then it is not a good sperm. Besides that, we have a 50 kilo sperm. Usually, grade 1 sperm 50% is sperm. So sperm analysis for a different only for a grade 1, grade 2, grade 1 so listen for grade 1 sperm more than that is the good quality. Yes. Therefore, also sperm count program develop 40 million, 100 million, 20 million. Right? 20 million is required. Correct? Active database capacity is the issue with the sperm and the information. So when you look at the idea of the supplement, I give next one is 20 to 40. 20 to 40 even এটা আটাই হতে পারে আনমার্টি হতে পারে তাই যে 50% মিডিয়াম আটাই 50% জান মিডিয়াম and it depends on so many factors. First thing is the behavioral factors. You know, the person cellular tissue, there is a chance of autoantibody generation in our tissue. So there is a concept of autoantibody. Second thing also there is trauma that what infects the position of what trauma, what that hamper the sperm production. Heart হতে পারে heart হতে তো সোশ্যাল ইকোনমিক ফ্যাক্টর অ্যাডাপ্টেশন ফর খুব মানে লোয়ার সোশ্যাল ইকোনমিক যদিও লোয়ার সোশ্যাল ইকোনমিক ক্ষেত্রে বাচ্চা বেশি হয় আপারে কম হয় so that is depend on the social economic status for আপারে কেন কম হচ্ছে because there is a anxiety, there is a alcohol intake, there is a smoking. So all these are, and also there is diabetes, hypertension, metabolic disease, all impact the function. So that's why the infertility is so common in the upper general upper of the so many diseases and the food habit of our. So that's why the upper system will that is infertility. So at the particular time the amount 2.5 to 3.5 that was the amount of adequate oxygen sperm count per hour then the sperm in a tube it is liquefied after 5 minutes because there is a presence of ESA phosphatic antigen that liquefies the sperm. So if you sperm kept in a tube for 5 minutes it becomes liquid. So through the dying cycle RCO that is the in normal sperm that is rich of fructose, glucose, etc. Because these fructose and these sperm that is provide the nutrition for the developing sperm. Function nutrition. After that so motility. Motility of the sperm. Motility is important factor. Though there is a 40 to 100 million sperm are present, only one sperm required to fertilize the other one. So, substantial fertilized sperm will take it to the level of so, this is the sperm analysis that we in the laboratory of here the technical laboratory is what I've done. So the amount, the facility, the count, the normal count, and obviously the abnormal count. Will be very few. If abnormal count are high, so there is a chance of the molecular so some are that is the way that we are analyzing the signal. Okay. So this is in short the topic. পরীক্ষায় কখন আসতে পারে তো একবার পর রিলেটিভলি একটা কনফিউশন নয় একবার পড়ি মোটামুটি ওকে
We're talking about walkthrough or saying to exam. We're going to talk about the development of the test sequence and the modifications of the development which is taking place after the development of the test sequence is done. In form of reset or relocalization of the test sequence and formation of mere external behavior, focusing on the development of urethra. And that urethral development is a prime concern in this particular case, external behavior development. Before we begin, it's going to be a little bit lengthy class compared to the rest of the classes. So if you feel any time home, walk down, you can move outside anytime. Alright? Please do not interrupt. Now, to understand the testicles, for that we have to understand the development, we have to understand the gross state. If you understand the gross state, then you can understand how this particular testicles and the component of the testicles are developed. So we already have done this particular thing in gross anatomy, but I'm just like redoing it so that we can just like pass and continue of it. So this is what we call them as testicles, which comes out like a cube like this. So this is the testis which you know. On top of the testis, taking a piggy bank right, we have these epigynes. So EG is the epigynes. It has some pain, body, cell, etc. Which continues as a tube. We call them as bags or vasicles. And that particular vas, before it empties into some place, you might put this particular gland-like structure like this, we call them as SB or semi-vesicle, and joins together to form this particular tube, we call them as ejaculator. And finally, bring the prosthetic part of the male urethra, and that is how this entire channel is complete. So when we talk about it, we're going to talk about the testicles, the vagina, vas, and semi-vesicle and ejaculator. That particular whole link of thing comes together as a package. Now, talking from this particular testis, and you see this particular testicles which has a covering, we call them as an external covering of the testicles. And this particular external covering of the testicles, we call them as tunica vaginis. Now, this tunica vaginis is the female layer which is covering to it, wrapping around. It has got two layers, visceral layer, right? Its tunica vaginis is nothing but its peritoneum. And that particular peritoneum is modified to give a special name to it as tunica vaginis. In short, we call them as tunica vaginis. Right layer and visceral layer, depending on how this particular layer is wrapping around the testicles. Now, histologically, if you turn this particular testicle, deep inside, we find a layer which is splitting this particular testicles into small chambers. We call them lobules. That particular small lobules which runs through this particular testicle substance divide these testicles into small. We call this particular substance which splits this particular testis into smaller segments or smaller channels as tunica albuginea. connected tissue material which is forming here. Now then, if you zoom this, understand this, within this particular nesticles or lobules, we find a supercoiled tube present inside fluid. We call them as seminiferous tubules. Now seminiferous tubules coming from here, from different chambers, joins together, forms a network of straight channels. We call them as RT, reed testes. And this particular reed testes forms this particular, joins together and forms this tunnel duct, which gets into this particular duct of the epididymis, and eventually epididymis goes into the vasculature. So this is how this microanatomy and the gross anatomy of testicles is related. Inside this particular small chambers, we have the blood vessels connected forming a layer we call this tubular vasculature. So this particular network of the testicles, how this particular takes a form, are important to understand what part is forming from what sections or what is contributing what. So this is what we are going to learn today about each and every segment of this part is going to form from which component or which embryological developmental components. Now when we talk about the development of testes, it comes into or falls into two different categories. One is testis itself that includes this reed testis. So testes including this particular seminiferous tubules plus reed testis. That segment falls from the category, and after that means this epididymis, the vas, the seminal vesicle, and the ejaculatory duct. That means beyond the reed testis, that means epididymis plus the vas plus the ejaculatory duct plus the seminal vesicle together. They are from different sources. They are from different components. So for developmental understanding, we divide this particular testis development into two segments. One is testis itself, with this particular seminiferous tubules, tunica oxygenia, and is covering to tunica vasculosa, and along with the tunica vaginalis, and along with this particular reed testis. Up to that part is sourced from a source, and other thing which is beyond this epididymis, which is sourced from another entity. That's what we are going to talk about. Now, the seminiferous tubules, if you see these particular seminiferous tubules, inside it we have an intricate layer, we call it the blood testis barrier, which is formed by a cell which is present inside. So if you see inside this particular testicle seminiferous tubules, there are two kinds of cells that are present within it. One is this particular cell, which is the sperm cells or spermatozoic cells, which is housed 95% of this population inside this seminiferous tubules. That is sperm, spermatozoa, dichotome, sperm beads, etc. Those elements, which are 95% of the cells. Other than this, we have this particular cell which is supporting this particular sperm cell. We call them as subscapular cells, also known as sarcomeric cells. Now the sarcomeric cells, which is supporting cells, and these sperm cells, which is germ cells, they are different levels. And other than this, between these two or adjacent seminiferous tubules, we might find some kind of cluster of the cells which are present outside the seminiferous tubules. We call them as IC cells, interstitial cells of leaf. Now, the cells are concerned inside this particular testicles, we divide into two different types. One is germ cells, other is support cells. Support cells are of two types: sarcomeric cells, which are feeding the sperm, giving nutrients, forming this protein for binding on this particular testicles with testosterone. We call them as testosterone binding proteins. They are synthesized by that. This is one hallmark of cells. Other thing is, we call them as interstitial cells of the leaf, which secretes this particular testosterone, which we transform into the active form, into the dihydrotestosterone, and which functions and circulates internally and externally. So the cells that concerned inside to this particular testicle are of two types. One is the germ cells and other is the resident cell. Now this particular germ cell and resident cell, why that, what you need, we already have explained. Now these germ cells, which is present 95% of this particular population of these testicles, which is by these people, are different types of cells. These cells are migratory cells. Migratory cells, that means they are not produced or not developed within these particular testicles. They come from elsewhere, settle down and grow and produce the adults. And resident cells, that means they are produced within this particular testicle, stands there, performs there. What are the resident cells? The sustainable cells, Sertoli cells, interstitial cells on the leaves. So these are the components. So again, this is what we already have learned. Now this is the beginning or the pre-phase of learning of this particular testicle. Unless you understand the components, you won't be able to relate these things and only able to memorize this thing, how this particular testicle develops and modifications of development as well. So this we have a cover into it, we call it as tunica vaginalis, which is basically a peritoneal fluid and the two layers, parietal layer and a visceral layer. Within this parietal and visceral layer of the tunica vaginalis, a thin capillary layer exists. That means a thin lubrication exists, nothing more than that. So remind that during that particular tunica vaginalis, we do not have anything that is lubricating fluid. That is very thin layer of fluid. That's the thing. Then if I keep behind this particular thing, which is known as the tunica albuginea, which is a connective tissue layer, which splits into this particular small lobules, and this particular lobules is occupied by this tube, we call it the seminiferous tubules. If I use seminiferous tubules, we get two pairs of cells housed in there. Germ cells, which are migratory cells, as I am saying, they are coming from elsewhere, and this particular resident cell, that means they are present within it, developed there, that means they are the kind of like named cells. And this particular named cells, which is present within it, we call that as Sertoli cells. Besides this, outside this particular seminiferous tubules, we do find some kind of another resident cells. We call them as interstitial cells of the leaf. They are capable of forming this testosterone. So this is called cellular. Now this particular tube, we call them as seminiferous tube, joins from different seminiferous tube, forms a straight tube, we call them as petechiasis. This is a network. Now this particular straight network joins together eventually give a single duct system. That single duct system forms from this particular duct of epididymis that is also supercoiled, remains within this epididymis and gets out of the epididymis and gets into this particular gas difference and then birth difference joins with the duct. Joins with this particular gland, we call them as seminal vesicle, and the duct of the seminal vesicle joins with this duct of epididymis forms a common duct we call this ejaculatory duct. The ejaculatory duct opens into the prostatic part of the. Now this particular development of the testis, which is all these things before this particular epididymis, everything is sourced from one source, and this particular tube system is developed from different sources. And this particular cells within this particular testicles are coming from two different. One is migratory germ cells, they are coming from elsewhere, and the resident cells, they are produced within this particular element. So with this, we begin with the development outline of the development basis, and then we're going to talk about this particular entity of development of monads. Now we talked about the development of these kidneys, which develops from the posterior abdominal wall of the developing embryo around 4 weeks of life. We call them as urogenital reach or urinary reach. This medial to the urinary reach to the posterior abdominal wall on the medial side, there is where this particular kidney is developed. Just beside that, mesometric kidney, where it is produced. Just medial to that, we find an area within this posterior abdominal wall, which is covered by this epithelium, we call them as coelomic epithelium. That particular region we call them as genital ridge. Now this particular genital ridge is basically the starting point of the gonads. That means taking testicles, taking ovary, they develop from this particular region. We call them as genital ridge. How this particular genital ridge looks like? This is this particular embryo and this particular posterior renal wall. We have this particular kidney developing over here. We see this mesonembric kidney. So we have the blood vessels getting in here. Immediate to that, we have this genital ridge which is present or lined by this epithelium. We call them as this epithelium and coelomic epithelium. Now this coelomic epithelium transforms soon and forms a different kind of epithelium. We call them as germ epithelium or germinal epithelium. So the hormones of the formations of this particular KP formations develop from the region we call the genital ridge. From the genital ridge, which is medial to this developing kidney region, genital ridge, and that particular genital ridge is the epithelium. We call them as coelomic epithelium. That coelomic epithelium transforms into a different kind of epithelium. We call them as germinal epithelium. Now this particular germinal epithelium around this particular genital ridge region transforms into two different entities. Now this particular germinal epithelium, which is this particular cell is there, is developing or arrange themselves into some kind of cord-like structure. So this particular cord-like orientation of this germinal epithelium within this particular genital ridge is a kind of elemental thing which happens in the baby stage. We call this cord-like fraction as medullary grace. Medullary grace or medullary cords. Inside the medullary cord, that means this particular germinal epithelium or germinal ridge or genital ridge develops into two regions, outer cortex and inner medulla. This inner region, which is housed by these connections or orientations of the coelomic or germinal cells, into this kind of pattern like this. So this particular pattern forms like a ray or forms like a cord. We call them as medullary cords. Now this much of development is common in case of the ovary or in case of this particular testicles. They are same. We cannot differentiate between whether it is going to be these testicles or this particular function is going to be the ovary. Unless until we have a determining factor. We call them as SRY. SRY region of the Y limb or long arm of the Y chromosome, which has a region we call them as SRY region. That particular region of the Y chromosome has a gene, we call them as SRY gene. And this particular SRY gene produces a protein substance, we call them as TGF. So this particular TGF is just this defining factor. If we have this Y chromosome, the SRY gene synthesizes this particular TGF or test is determining factor, then this particular region is going to be tested. And if we do not have this particular Y gene, we do not have the test determining factor, this germinal ridge is going to be the ovary. So, having this testing determining factor which is present, this particular medullary grace arrangement is further condensed or further intensified. So this particular grace or medullary cords which you see here is further amplified if you have this TGF, testing determining factor. So we have this particular picture over here. This is how this particular cord pattern is formed. So this is the future genital ridge region. You see that initially, and with this influence of TGF, this particular cellular arrangement is occupying over here, eventually transforming into this particular ray-like pattern. So this particular ray-like pattern is called as medullary cords or medullary grace. This is only formed if we have this particular region with TGA or tested determining factor. So this is how this particular rays are formed. So this particular medullary cords which you see here So this medullary cord, so for example, we have 100 medullary cords like this pattern is there. So we have these 100 medullary cords, and 95 to 97% of these medullary cords will be canalized. Once they canalize, they form this particular element. We call them as semi-nephronous tubules. So this is the cord eventually gets canalized. That means the tunnel is created and forms the semi-nephronous tubules. How many of them? 95 to 95%, 97% of these cords will be canalized and form a tube. That tube we call the semi-nephronous tubules. Now, 3% of these cords are not canalized. So those 3% which are non-canalized, they form cells. What cells? They form these interstitial cells of the knee. So this non-canalized medullary rays, which is very few, will be forming these cells, which is known as interstitial cells of the knee. And all these cords which are canalized are going to form this semi-nephronous tube. So this much of development is influenced by testing determining factor. If you do not have the testing determining factor, this cord will disintegrate and form this oval, or the terminal epithelium of the bone. Understood? So this much is there because to the sources of interstitial cells. Now within this semi-nephronous tube, so majority of the cells which is forming the cords will be canalized to form the semi-nephronous tubules, and within the semi-nephronous tubules it creates the tunnel, and along with that inside to it forms the cells which is known as Sarkozy cells. So the Sarkozy cells and the interstitial cells of lady, they are indigenous cells. They are formed within this element which is known as genital breech and this medullary cord is continuing. Now, the other cells, which is the main cells or the main populating cells, as I mentioned, they are known as germ cells. Now, germ cells are migratory cells. They come from elsewhere, produce it elsewhere, move to there, settle down, produce. Where from they come? They come from this particular region of the developing embryo. We call them as yolk sac. So this particular yolk sac, you see that the yellow one represents the ventral body wall. In this wall, we see this particular migratory primordial germ cell. They pick up the sensation, be it ovaries, be it testicles. It doesn't matter. This germ cell, they come over here and settle down. Eventually, with taking a migration path through this particular mesentery, reach to this particular region of this artery. If the semi-nephronous tubules is produced, they get inside. If the semi-nephronous tubules are not produced, they remain scattered within this particular developing gland. That's going to be the future way. So this is how this particular migratory cells move from this region. We call them as yolk sac migratory cells. Make the amoeboid movement takes up this particular ventral mesentery. From the ventral mesentery, they reach up to this posterior abdominal wall and settle down over there and populate and produces this. Depending on how this gonad is there, how this particular gonad is producing this particular organ, which is known as depending on why chromosome is there or not. If you have PDF or not, they take the modification pathway to become sperm or ovum, depending on this data. So this particular entire thing of this particular germ cells which migrates and the different cells which remains over there is under the stimulation of SR5 gene, which is present on this particular region of the Y chromosome. So if you have this health subject, this SR5 gene matters to them. If not, it will be transformed into it. So this is the sequel of the thing. Absence of this particular Y chromosome will be here, then it becomes ovarian orders, it will be just like this. Following this one, now, coming to this particular testicle, this one we talked about medullary vein and medullary wall. So this particular thing, further amplifies, this particular thing is canalized. Now you can see this particular canalized part of the semi-nephronous tube joins together, forms the breathing gases, and this particular breathing gases forms this particular duct, which is known as efferent duct, over there and gets into the epidermis. Now, up to this much, this particular centimeter tubes along with this partial shadow to different tubes, this much is formed from centimeter tubes. Where centimeter tubes is formed, different tubes are formed from this particular regular grade or membrane box. Now beyond that, this part which is known as the epidermis and beyond part, where does it develop? This part develops from this particular region. We call this as the mesonephric ducts and mesonephric tube. Now see that in this particular picture we have this particular kidney which is forming over here, and this particular kidney which is the mesonephric kidney has got tubules. So this particular tubules of the mesonephric kidney are there. Now we know that this mesonephric kidney is short-lived. We have a better version coming. So this particular tubules and this kidney are replaced by. So this particular kidney is completely reduced and reduced or replaced by the better version. What happens to this particular kidney tubule, which is known as mesonephric kidney tubules? Now this mesonephric kidney tubules, majority of them are absorbed or vanished, except few parts of it. So few parts of this particular kidney mesonephric tubules, they are taken up by this particular developing testes. So mesonephric kidney remaining tubules, they are taken up by this particular developing genital leaves, and they are incorporated within this genital leaves, and they form this particular duct system which is beyond this particular retestisome, and they form this particular epidermis, vas deferens, seminiferous tube, seminal vesicle, and ejaculum. So that's why we made this particular RNA distribution feature about seminiferous tubules of testicles and this retestis and everything beyond. So this particular kidney tubules which is remained there, some of them are remained there, they form this particular duct system. They come close to the mesonephric tubules, which is the orange shadow, getting slowly by this genital leaf, getting absorbed within this genital leaf or developing testicles, and being utilized as an outflow tract of this particular cement system, and eventually this particular mesonephric tubules gets into this particular retestis or the different duct tubes, eventually merging and forming this particular eventual duct tubes in the supercoil epidermis, and epidermis beyond this particular thing comes at the vas deferens. The vas deferens goes into this ejaculatory duct. Before that it forms the seminal vesicle, joins together. After that much, this particular thing is formed. So this is how this entire story of this particular development of the testicle is going on, from the genital reach, tube system of this particular seminiferous tubules and the ejaculatory duct and this particular epidermis and this particular vas deferens of formation of this. The entire story of this gonad formation taking place inside the abdomen, posterior wall, 6 weeks, 4 weeks to 6 weeks of time. The whole thing is formed there. Now, after that, next phenomenon which happens over here, we call them as the descent of testicles. We do not know exactly why these testicles are pushed outside the abdominal cavity, because the ovary remains inside this pelvic cavity. Though it's not this particular abdominal cavity, but it remains in the pelvic cavity. But this particular testicle, why it is pushed outside all the way out, we don't know yet. But anyways, there are some factors which actually triggers the movement of the testicles from the abdominal cavity to the pelvic cavity to the middle region to this particular spot. So this is how we have to trace this pathway, how these particular testicles have moved down from the posterior abdominal wall to the scrotal sac, and you have to travel or take this particular track. So this is how it is going on. Posterior abdominal wall, then it moves down to the pelvic wall. Once it moves out of the pelvic wall, it has to be pushed anteriorly to the anteabdominal wall, or lower part of the anteabdominal wall. The lower part of the anteabdominal wall, it creates this particular tract, which is known as this inguinal canal, which has 2 openings. We have this superficial opening, then we have a tract, then we have a deep opening like that. So this superficial deep opening of these things helps us to if this particular passageway for the testicles from the abdomen to this eventually reaching to this particular scrotal sac. So this is the normal track of this particular testicle descent. Now there are factors which is helping out. Of course, the testosterone on that. Under the surface of this particular testicles, we have a connective tissue network of mesenchymal element. We call them as glucuronidulum. That particular glucuronidulum shortens and pulls these things out, and eventually helps this out. And the convexity and as well as the intra-abdominal pressure as well helps this particular movement out. But this particular descent of this particular testicle, which is happening from this lumbar region to this scrotal sac, which is taking some time, inside that particular stimulated band, it is descending out. See that during the third week after the development is done, starts the journey, taking of this particular peritoneum over here. So this peritoneum over this particular region of the abdomen, it takes off. That particular peritoneum, we call them as processus vaginalis. We call them as some sort of processus vaginalis. That peritoneum, which takes from this abdomen cavity while this testicle is moving out. So processus vaginalis is a kind of important landmark to understand. So it takes this peritoneum, the burden of আসর নিয়ে বেরিয়ে চলে যাওয়া ওই যা যা পেয়েছে এখান থেকে টিভি পাইনি ব্লাড ভেসেলস পেয়েছে লিম্ফ্যাটিক ড্রেনেজটা পেয়েছে so we got all these blood vessels and lymphatics and we got some kind of weird shit around which is the process of vaginalis which is the mesentery which gets around here takes it so takes this into that 3 months of life it takes this particular region of that lower lumbar region we call that the real process. After 3 months, it takes a 6-month course, taking this particular immunal pathway, reaching from the iliac fossa to anterior wall, moving that part, and reaching to this particular deep treatment, 6 months. 7 months, through the canal, it travels to the canal, immunal canal, then it comes down to the superficial breed, 8 months, and just before part, it reaches, by the 9 months, it reaches to this particular scrotal sac, this new arm. So what it takes along with this particular journey, the blood vessels. What blood vessels is the arm? You have seen that testicular artery runs a long course coming from that all the way to the lumbar region of the abdominal aorta going down, taking with it. The lymphatics, in fact, remains in the lumbar region. The lymphatic resides there. I'm not going to make a movement over there. So lymphatic drainage of the testicles is on the lumbar region. So if you have a testicle tumor or the septum of testicles, and the immunity going on, and we have this lumbar immunity node. Anyway, so this particular region, we have this particular scrotal sac at this particular cave of this arm. Now, how it reaches this particular crest, iliac fossa, liquid, renal canal, superficial inguinally, and the scrotum. So this is its normal route 66. So this particular route is normally taken by this particular descent of testes. Now, during this particular process of descent, as I am saying, there are a number of factors that trigger this particular descent. So this particular test is moved from the posterior wall, moved to the anterior wall, iliac region, it brings superficial canal, superficial ligaments scrotum. This is how it is getting done, depending on this particular week, such as 6 weeks, 8 months, 9 months before born. This is how it is going. There are a number of factors which is figuring over here. Of course, this particular thing is regulated by this hormone, which is the testosterone, and this particular thing is called the glucuronidulum testis, which is a hypomuscular band or mesenchymal band, pulls this particular testicles. Along with this kind of like a group of the body wall, all this particular intra-abdominal pressure, other things that this particular propagates this particular process of movement out. Now this particular whole process, as this particular testicles is going on, this is the normal track. Now this descent of the testicles can be any point be arrested. So it will be, as this particular testicles is going down through this track, anything can go wrong. And they can suddenly decide, I'm not going outside, I'm going to stay there. Now that particular phenomenon, if it is happening, this particular testicle instead of remaining to the scrotal sac, remains around this particular regional tract where it should be traveling through. We call this particular phenomenon as undescended testis. Undescended testis, also known as premature, so which is an anomalous condition, we call this undescended testis. So we have to pay attention on this particular part called undescended testis. What we mean by undescended testis is that the testis remains on this particular normal track, whatever it is traveling to. It could be it could be ring, it could be like an antennal wall or this particular region on this particular territory where it should be there. Even it could be inside the abdomen cavity. So this particular region, in this particular phenomenon, where the failure of the testicle descent is there, as I said at this particular point, we call them as undescended testes, also known as pictorialism. This is one thing. Now, there could be another thing. The testicles may be very unruly. So it may be behaving weird. They say, I'm not going rather I'm just like living for somebody else. So it can run anywhere. So in that case, if you find the testicles, instead of this particular normal track, some elsewhere, that particular positions of the testicles, we call them as ectopic testes. So that particular entity is very close, we call them as ectopic testes. That means it could be anywhere. It could be like the abdomen, it could be inside this particular thigh region, it could be just like in the perineum. So these are not the normal positions of this normal position track of the descent of the testicle glands. You understand the difference between the undescended testes with this ectopic testes. So these are commonly being given examples in the exam questions like ectopic testes and undescended testes. And many a times, and most of the times, we read the things as saying that undescended testes is equal to the ectopic testes, which is not. Am I clear? So the ectopic positions of the testicles is abnormal positions where it should not be there. It is there inside the perineum, inside this particular thigh, or this particular femoral tree, where this particular region is there, or femoral canal, it may be trapped there, or maybe just like any point in this particular wandering inside the abdomen of the pelvic cavity, not in that particular tract. So this particular entity of this femoral, penile, or perineal, or symphysis is kind of like a ectopic position, and whereas this entity undescended has to be like that, like deep brain, canal, superficial, any part within this particular descent tract, it may be arrested. So this is about this particular testis and descent of the testis as a phenomenon. Now let's move to this particular other clinical important part of the testicle area, which is important to us, is this one. As I have mentioned, when the treatment is getting out of this abdominal cavity, it takes nothing other than the peritoneum fluid. That particular peritoneum fluid, when it takes it, we call them as processus vaginalis. Now that particular processus vaginalis gets modified as it is getting out. So this particular peritoneal fluid, we call them as processus vaginalis. In adult, we call them as tunica vaginalis. And tunica vaginalis is normal thing, which has varietal layer and visceral layer. So this processus vaginalis cuts off, which is a large chunk of tissue or a large chunk of peritoneum. It takes along with it and remains like this. So eventually it gets streamed and forms this particular thing we call as processus vaginalis into tunica vaginalis. So tunica vaginalis is a thin layer of this peritoneum covering around the testicles, which is normally seen. Now if by any chance this processus vaginalis fails to tailor, fails to be modified, it remains as it is. We get a large amount of processus vaginalis like this. And within this particular processus vaginalis, it has two layers as well. The visceral and parietal layer, fluid accumulates. So that particular fluid, if it accumulates within this persistent processus vaginalis, we call them as hydrocele. And that particular hydrocele is happening in the kid, newborn kid, just born kid, with a huge testicles. We call them as congenital hydrocele. Now, congenital hydrocele is nothing but persistence of PV, processus vaginus. It could be small, it may be cyst like this, maybe trapped in here like this, maybe have a connections like this, or may have a complete tract connection like this. Along with this hydrocele, you may have the hernia as well. So you see that intestinal coils getting into this process of vaginalis and creating a kind of hernia here. So we can get a congenital hydrocele along with congenital hernia. So if this small entity, we call them as PV, processus vaginalis. So we have to understand this particular thing. So processus vaginalis, that is only be present when this PV is settling out. It normally should be present. But once this PV is settling down to the scrotal sac, this processus vaginalis should be transformed into tunica vaginalis. If it is not, we can get various kinds of illness in form of the hydrocele, encysted hydrocele, or maybe hydrocele along with these herniations of the gut. We call them as congenital pneumonia hernia of congenital hydrocele. So these are the different varieties of this. Again, this is your exam questions. We ask this particular questions about the developmental basis of congenital hydrocele or congenital pneumonia hernia. This is what we have to explain why this particular kidney is, why this particular testicles is descending out. This may be just like getting this particular thing transformed from processus vaginus to this. And if it fails to do that, we can get this particular various form depending on whatever it is. It may be congenital hydrocele or maybe encysted hydrocele or maybe this particular along with this just like this. So these are the two important landmarks of this testicle era or anomalies of the testicle that we have to know. So this is what normally it should be looking like. So this is what normally thing is that this particular testicle is separated from this particular abdominal cavity and this particular tract is obliterated. We call this obliterated process of vaginas. If it fails to obliterate, we have this disease. And this is how this particular remains of breathing you are seeing here. This is the main thing we are referring here is that tunica vaginus. So tunica vaginus is this tube there. So this is how this accumulation and this particular hydrocele can be taken place. Now again, this particular entity about factors, depending on factors of this particular thing of descending testis, this is what we have to understand basically how this particular testicles form and how these things are propagated out, what are the factors assisting it. Second thing is that the anomalies of it, we call them as congenital hydrocele or maybe undescended testis or maybe ectopic for the testis. So this is what you have to prepare very well for the exam, clinical exam questions related to it. Seminoma of testicles is a kind of disease condition. The medullary base cell which is existing, like salivary cell or intestinal cells, can abnormally behave in large and create a tumor called the seminoma testicles, which is a tumor of testicles which often happens to the young individuals. So this is what also we have to know about. When this testicles is usually enlarged, mimicking like hydrocele. Eventually, it is basically a solid tumor and present like this. So this is about the testicles and this thing. Vertical cells and the formations of vertical genital tract. I think those are being covered. And we are going to talk about the last entity. It is prostate. this particular day we need to cover the last thing about male external genital formation. So this is very short content where we are going to focus in here. So again, taking back to this 6th week of life, this is the perineum region of the 6th week of old individual. We have this particular area which is occupied here, is known as cloaca. We talk about the cloaca, it's a blind pouch. That particular cloaca blind pouch is covered by a membrane which calls the cloacal membrane. And this particular cloacal membrane, by this migration of the mesodermal cell, which is coming between the urogenital sinus, it's split into two parts, one part anteriorly and one part posteriorly. It forms this anal membrane and anal canal posteriorly, which is a smaller canal, urogenital membrane and urogenital sinus in the anterior part. This anterior part, urogenital sinus, and posterior part, anal canal, in between them, we get this particular tissue, we call it as perineum. We talked about it. So we focus about this particular phase of this particular region, we call them as urogenital sinus. Now, within this particular urogenital sinus, as this particular thing transforms from 6th week to 7th week, there are one thing which is transforming here. On the bulge which is coming over here to the midline, in top of this particular urogenital sinus or urogenital sinus membrane or urogenital fold region, we call it as genital tubercle. This is the midline swelling. And next to this particular midline on the side, there are two other swelling which is coming up, which is known as genital swelling. So there are three swelling coming up. 1, 2, and 3. Two lateral, one midline. So this genital tubercle and the genital swelling, they transform and fuse or unfuse to form the male and the female external genital. Now, in short, this particular genital tubercle, we take it at a time. First, the genital tubercle, what it transforms, and later on subsequent. As we are going to talk about this particular male external genital here, this particular genital tubercle, with influence of this particular testicular hormone, which is known as the testosterone, it grows. So this particular genital tubercle grows or elongates and forms this particular elongated part of the genital tubercle, which is known as a phallus, also known as the male penis. So this particular male penis is under influence of this hormone testosterone or antiversal versus dihydrotestosterone, elongates this genital tubercle to form a phallus or tube-like structure. That tube-like structure goes to form this primitive penis eventually. And then we have this particular fold, we call it as genital swelling, which is right and left. Now this particular genital swelling which is present in here forms this particular midline rift or midline cleft like this. So this particular midline rift or midline cleft, we call this as midline region as urethral plate. Now this particular urethral plate soon gets into this particular developing phallus, and this particular phallus makes it groove and forms this urethra. So this is how this particular urethra is formed. That's what you have to understand. This is the male phallus which is formed, the undersurface of the tissue of the male phallus, which has this particular previous tissues like this. This red tissue which is known as urethral plate gets in, and slowly within this particular urethral plate, it forms a groove. This particular groove which is running over here, we call it the urethral groove. Now in the groove midline it mates and forms this particular tube which is known as urethra. Now this particular urethra which is formed within this particular male organ penis or primitive penis, also known as phallus, is running throughout the phallus length. So this particular formation of this urethral fold into this urethral groove from the urethral groove is important. Now why it is important is this. Now you see that this particular interval is male penis. Now this particular part we call this body, the front part we call this gland space. So soon we have a coronal sulcus appears and separates this particular male penis with this gland space. Now see that this particular urethra or penile urethra which is formed like this with this urethral groove like this runs only up to this particular penis body. So this particular part, which is dilated part of the male penis, we call this as the glans penis. Do not have any urethral opening. So that particular urethral opening is absent within this particular foremost part of this male penis. We call this glans penis. So this thing has to be presented or has to be created by this inverting solid ectodermal tissues. So this inverting ectodermal tissue from the surface of the gland penetrates and creates a tract, and this particular tract canalizes and creates this final canalized ectodermal mass, finally canalized and mixed with the urethra, and the entire tract is there. Now, if anything, this particular ectodermal mass, if it is not formed, this particular penis, which is not been having this particular opening in the tip of the penis or tip of the glands, then this particular urethral opening will be on the undersurface of the penis. So then we have a disease condition, we call them as epispadias or also known as hypospadias. Like this, there are different varieties of them. This is what is important to us to understand the development of the penis in forms of this. So again, I'm just like talking about here because we get the questions coming over here. This is another penis of animals developing from the midline directed tubercle. Within this, we have this particular urethral plate growing in here, creating the groove and this urethral final. But this is not reaching throughout the length of the penis. It is falling short of the anterior part of the male penis, which we call them as glans penis. At that part of the glans penis, the surface ectodermal skin has to penetrate back to make this particular urethra, and then this entire tract is created. If not, this opening of this particular urethra will be under the surface of the penis. That is a disease condition, and surgically you have to correct it. If not, it may be just even short. It may be just that this particular thing is maybe not short, not formed. It may be there in this total thing. So this canalization of entire penile urethra to this particular formation of the solid ectodermal mass is important. So this is what we have to talk and we have to understand. Now this is what I am talking over here. Is this abnormal opening of the urethra. As I am saying, this particular urethra is formed on undersurface of the penis by forming this fold. By any chance, if this particular urethral fold is faultily formed, it can create an opening in the entire length of penis. So you see that no urethral fold is formed. The penile urethra, that means this particular unit is going to lead to this perineum unit. So this is between this anal canal and this scrotal sac. Between them, this unit is leaking out. This is the way this right. We have partially formed this particular urethra or male urethra. It may be within this particular penis and the scrotal junction, called the scrotal opening. Within the shaft of the penis, it may be opening. It may be just like in the part of this particular tip of this region where we see this most common form, and we can see this undersurface of the glans penis, it may be opening. So this particular abnormal opening positions of this particular urethra, we call them as hypospadias. Now this is your example, that what we see that. What do you mean by hypospadias? That is short note. And what fault is being happening over here? It is rather than the basis of that. It is nothing but the canalization of the ectodermal cord is failing to take place. So this entire urethra is not opening on the tip of this male penis, which is in the glans penis, it should be opening, and leading to this abnormal opening. It could be anywhere between these particular entities, like undersurface of the glans penis, undersurface of the shaft of the penis, peniscodal or perineum. So this is what you have to understand. With regard to this particular male external genitalia, which is there, you have to understand. It is hypospadias. It's very important for the exam form. So, and well, we see the clinical cases as well in the clinical trial. There are other variety of hypospadias is there, we call them as epispadias, where this particular opening of the urethra on the upper surface of this particular male penis. This is insert that we are going to talk. So, stop at this particular point, emphasizing on what we have done. about this particular set or about this particular formation of this particular testis. If you remember this particular undecided testis, ectopic testis, and the hydrosis very well, there are little basics and I'm going to presentation of that. And as well as this particular urethra formation, the urethra, the abdominal portions of the urethra becomes all as hydrosis. So this is all which governs this particular content of this particular exam topic in this semester 1 and semester 2 for the analytical section.
Upper jaw, okay, or it is also forming the alveolar process, the upper alveolar process, okay. And what are the thing? Tell me about the ossification. How does the maxilla ossifies? How many maxilla we are having? 2, both side, okay. So it is also forming what? What is this? This is the hard palate, okay. So how this hard palate is formed? You could find, I mean base of skull bolechhilam, it is forming one midline suture. So that is also known as intramaxillary suture, okay. So write it down about maxilla. Maxilla is forming the upper jaw. Maxilla is forming the upper jaw. Okay, so write it down. Maxilla is also known as the upper jaw, okay, and it is forming the facial skeleton, okay. So there are 2 maxilla which is forming the upper facial skeleton on the both side, okay, and in between it is joined at the hard palate, okay. So could you tell me how much the hard palate is formed by which bones? This is the hard palate, right? So it is formed by which bones? Maxilla and arekta ki palatine, okay. So anterior 3/4 is by maxilla and posterior 1/4 is by the palatine, okay. This is the hard palate, and if you see this area, this should be for the soft palate, okay. So what are the other thing is known? Already I told you, so just write it down. 2 maxillae are joined together. 2 maxillae are joined together at the hard palate, and forming the intramaxillary suture. Forming the intramaxillary suture. Eta to intramaxillary suture. What about this one? Tell me, this is the intramaxillary suture. What about this one? Eta jodi intramaxillary suture hoy, here is the situation of palatine bone. So it is also known as palatomaxillary suture. ঠিক আছে, এই দুটো suture is crossing together, so that's why it is also known as cruciform suture, okay. ভাইবাতে জিজ্ঞাসা করতে পারে, as because these 2 suture are crossing together, so this is also known as cruciform suture, okay. So now see how many parts this maxilla is having. So write it down, how many parts this maxilla is having. So number 1 is there are 4 processes, okay, very much important. This much small bone but has got 4 processes, okay. So what are the process? See, this is the alveolar process, okay. So where the tooth is there, so that is known as alveolar process, okay. Then the next one is, this is the anterior process. Anteriorly it is faced, so anterior process. This is what it is making joint with which bone? That is the frontal, okay. So this is the frontal process, and this is joined together with zygomatic, so that is zygomatic process. And another one towards this side, that is known as infratemporal, okay. So write it down. Number 1 is zygomatic. 4 processes. Number 1 is zygomatic. Inside in bracket you write, it is also known as lateral process, lateral side, okay. Zygomatic is lateral process. Then next one is frontal. Frontal is forming the superior process, okay. Then alveolar is also known as the anterior process. Alveolar is also known as the anterior process, okay. And palatine is also known as posterior process. So which side it will unite with the palatine? See over here, this area, this is the frontal process, means towards medially it will attach with the palatine. And which part of palatine? It is also known as PPP, okay, perpendicular plate of palatine, understood? It will articulate with perpendicular plate of palatine, So see, if you see the bones, see the now the structure, so you could find it out which one is the alveolar process. Okay, so which one is the alveolar process? This is the alveolar process. Okay, and what is this? This is also known as maxillary tuberosity. So which one is the maxillary tuberosity? This is the alveolar process. And see this tuberosity. This is also known as maxillary tuberosity. Okay, and this side also you are having the palatine process, which will articulate with the palatine bone. Okay, and here is the situation of nasal concha. Now what are the concha or meatus? What I told, how many paranasal air sinuses are there? And what is the importance of sinuses? কতগুলো প্যারানেজাল এয়ার সাইনাস থাকে? Means these bones are also considered as pneumatic bone. তাই তো? তাহলে কোন কোন বনে থাকে? And it would be situated just peripherally to the nose. Number 1 is maxillary air sinus. Write it down. Paranasal air sinuses are, number 1 is maxillary sinus. Maxillary sinus. Then second one is the frontal sinus. Frontal sinus. Okay, sphenoidal sinus, sphenoidal sinus and ethmoidal sinus. There are 4 types of sinuses. Okay. So these sinus, these are the sinus, right? It is, what is the function? Tell me. What are the function? There are 3 functions. Write it down. Very much important. What are the function of sinus? First one is, it is making the skull lighter in weight. Okay, সবার আগে light করে দিল weight of the brain, because brain is 1.5 kg. So the skull has to be lighter in weight. Then second one is, what are the other function? It act as a air condition. Okay, it act as a air conditions. Okay, this is the second function. And the third function, to produce the resonance of voice. Okay, third one is to produce the resonance of voice. So if you see this each and every meatus, it will open into each and every concha. Okay, so what you have to do? You have to do one sagittal section of the head neck. Okay, puro jodi sagittal section means you are cutting from left and right. So you will get each and every sinus opens where? Okay, so that are known as concha or the meatus. Understood? So we will see in the gross anatomy what are the thing. Okay, so now see which one is the infratemporal surface. Konta infratemporal surface? This one is the maxillary tuberosity. This area is also known as infratemporal surface. Okay, that means which is just below the zygomatic process. Okay, just below the zygomatic process, and this infratemporal surface is also very much important. Okay, so I will show you which one is the infratemporal surface. Now see here, this is the zygomatic process. See everyone, this is the zygomatic process. So just below you are getting one part of maxilla. Okay, although it is not a part of temporal bone, but it is found where? In the maxilla. So this is also known as infratemporal process of maxilla. Okay, then the second one is, there is one groove. So which one is the groove? We will see now which is the groove over here. So for what is the anatomical position? See, always frontal process would be directed upwards. Okay, and alveolar process would be directed downwards. Zygomatic process would be laterally and palatine process would be medially. So this is the anatomical position. Now you will see one groove over here to the palatine process. Okay, so this groove is also known as infraorbital groove. Very much important, infraorbital groove. So tell me, from the skull, norma frontalis, infraorbital foramen, which one is the infraorbital foramen over here? কোনটা infraorbital foramen এখানে? Which one? This is the infraorbital foramen. Okay, this is the infraorbital foramen. Which thing passes? Facial artery কোথা দিয়ে যায়? It is going to the angle of mandible, তাই না? Angle of mandible দিয়ে যাচ্ছে, তাহলে এখান দিয়ে কি যাচ্ছে? Supraorbital foramen একটা পাচ্ছে, এটা infraorbital. Supraorbital দিয়ে কি যাবে? Ophthalmic division of V1 of trigeminal. Okay, then infraorbital দিয়ে কি যাবে? Write it down. Infraorbital foramen very much important. That is for the infraorbital nerve and vessels. Infraorbital nerve and vessels. Now infraorbital nerve is a branch of maxillary division of trigeminal nerve. Maxillary division of trigeminal nerve. So that is the V2. Okay, trigeminal nerve kota division? There are 3 division. One is ophthalmic, then second one is maxillary, and the third one is mandibular. So which thing will be passing over here? The maxillary division of trigeminal nerve along with infraorbital vessels. Understood? So these foramen, how does it will come? It will go through this groove that is also known as infraorbital groove. Okay. So what are the other thing you could see over here? See what is this? This is the infraorbital groove. See everyone, this is the infraorbital groove. Okay. And what is this? This is known as the lacrimal notch. What about this opening? Could you tell? Opening ta ki? Maxillary sinus. Now the question is how the maxillary sinus is closed. Maxillary sinus is one of the part of maxilla, but it has to close to forming one sinus. Write it down. How does it will close? So maxillary sinus is greatly reduced by first one is the uncinate process of ethmoid. Uncinate process of ethmoid and lacrimal bone from superiorly. Inferior nasal concha from inferiorly. Okay, and again the PPP, that means perpendicular plate of palatine from the medial side. So this thing question may come. How does the maxillary sinus get closed? It is one of the part of maxilla, but these 3 bone will form the complete sinus. Okay. Now tell me, sinus, if you see the maxillary sinus, how does it will look? It is looking like a triangle. Okay. So that means it has got one apex, one base. Now the question is, base is facing where and apex is facing where? So write it down. Apex faces laterally to the zygomatic process. Apex faces laterally to the zygomatic process. Whereas base is faces, base তাহলে কোথায় ফেস করবে? Triangular তো, apex টা চলে গেল to the zygomatic process. তাহলে base টা কোথায় আছে? Towards the nasal cavity. Okay, it is towards the nasal cavity, and where it opens, write it down. Maxillary sinus opens into the middle meatus. Very much important. Okay, maxillary sinus opens into the middle meatus. এটা কিন্তু question আছে যে supreme meatus এ কে ওপেন করবে, superior meatus এ কে করবে, middle meatus এ কে করবে, inferior meatus. maxilla তে দুটো জিনিস পাবে, একটা হচ্ছে maxillary sinus কোথায় বললাম ওপেন করে, that is the middle meatus, and the another one is nasolacrimal duct. Write it down. Nasolacrimal duct, it opens into the inferior meatus. It opens into the inferior meatus. So why I said the nasolacrimal ducts? Now you could easily identify the lacrimal notch. Okay, this is the lacrimal notch. So see over here, it will form one groove. Okay, so this is also known as nasolacrimal groove, and nasolacrimal groove is one of the part of lacrimal apparatus. Right? So what are the part of lacrimal apparatus? Laterally ke thake lacrimal gland, tear has been secreted. Okay, now it is going where? To the lacrimal sac. Okay, now it is going towards the nose, that is the nasolacrimal duct. Okay, so this nasolacrimal duct open into the inferior meatus. Okay, so these are the important thing you have to know. Okay, now about the body of maxilla. If you see the body of maxilla, so which one is the body? These are the processes. Okay, projection from the maxilla. So which one is the body? This structure is the body. Okay, so body has got how many surface? Write it down. The body of maxilla has got 4 surfaces. Again 4 surfaces. This is the anterior surface. Anterior surface, this one where you will get the infraorbital foramen. Okay, then this is what? Which is making the floor of orbital cavity. Okay, so write it down. Orbital plate of maxilla. Okay, and nasal is towards medially, and another surface is infratemporal. Just now I have shown infratemporal. So the body of maxilla has got 4 surfaces. Anterior, then superior is the orbital, medial is the nasal, and lateral is the, what is the lateral? That is the infratemporal. Okay. So these are the 4 surfaces. Now see over here, what are the other thing you will get? This is the orbital surface. Okay. So it is making inferior part of the orbital cavity. Now tell me how the orbital cavity is formed, by which bone? কি বোন থেকে তৈরি হয় এটা orbital cavity? If you see the boundary, lower one is the orbital plate of maxilla, lateral one is the frontal bone and the zygomatic bone, superior by the orbital plate of frontal. What about the medial? That is the most complicated one. Medial part is formed by first one কি আসবে? lacrimal, lacrimal আর কে আসবে? nasal আসবে, nasal, lacrimal, and another one is the palatine. Okay, orbital cavity কিন্তু boundary জিজ্ঞাসা করে। and this fissure, you know how does it form? by the lesser wing and the greater wing of sphenoid, তাই তো, যেটাকে বলে superior orbital fissure, superior orbital fissure. So it would be formed by the lesser wing and the greater wing. Now see over here everything. First one is the, this is the frontal process. So frontal process e ki pabe? First one is the lacrimal groove and this is the orbital surface. Okay. Then this one is the infraorbital foramen, infraorbital foramen. Okay. And what is this? This is, if you see the anterior aspect of maxilla, এই পার্টটা যদি দেখিস, which are the tooth you will get? maxillar এখানে কি কি টুথ পাবি বল? which are the tooth you will get? First one is the incisor. So above that সেটাকে কি বলছে? incisive fossa, তাই তো। তারপরে তুই পাবি canine, canine এর উপরে আরেকটা fossa পাবি, that is the canine fossa. So now question is, which are the muscles that are attached over here? Yeah, আর at first এখানে কি থাকে? incisive fossa, write it down. incisive fossa তে থাকবে depressor septi, one of the muscle of nose. Okay, যেটা nasal septum কে depressed করছে, so that is known as depressor septi. Okay, then beside that, see over here, then beside that another one that is known as incisive fossa. Okay, so incisive fossa কার জন্য? depressor septi. then canine fossa তে তাহলে কে attached হবে? incisivus superioris, incisivus superioris, incisivus superioris. Okay, আর এই এরিয়াটা, if you see the this frontal process, this area has been attached by 2 muscle. একটা হচ্ছে levator labii superioris আর levator labii superioris alkanazai. Okay, just write it down. The anterior aspect of frontal process of maxilla, anterior aspect of frontal process of এই জায়গাটায়, okay, anterior process of frontal process of maxilla, there are 2 muscle that has been attached. One is levator labii superioris, levator labii superioris, আরেকটা কি বলেছিলাম সবথেকে লেন্দি মাসেল? levator labii superioris alkanazai. Okay, these are the 2 muscle that has been attached over here. What about this area? This area means if you are going backwards to the zygomatic process, this is for the buccinator, very much important. এখানে কি attach থাকবে? buccinator. Okay. Now what about the alveolar canal? Tell me, which thing would be going? alveolar canal দিয়ে কি যায়? Any idea? You could not perform any dental procedure without blocking this nerve. So that is নার্ভটার কি নাম? posterior superior alveolar nerve. ওপরেতে যেটা থাকে সেটা হচ্ছে superior alveolar nerve which is coming from the maxillary nerve, আর inferior jawতে কি থাকবে? inferior alveolar nerve which is coming from the mandibular nerve. বোঝা গেল? দুটো জয়ের নার্ভ সাপ্লাই আলাদা। সো রাইট ইট ডাউন। alveolar canal কতগুলো থাকে? 2 to 3, একটা থাকে না কিন্তু, 2 to 3 branches from the posterior superior alveolar nerve, posterior alveolar nerve which will open into the oral cavity. Okay, which will open to the oral cavity. Now if you see the interior aspect, that frontal process এর এখানে you could find it out, there is one crest. Okay, এই ক্রেস্টটাকে কি বলছে? ethmoidal crest. বোঝা গেল? ফ্রন্টাল প্রসেসে একটাই ক্রেস্ট পাবি, that is known as the ethmoidal crest. Now if you go downwards, what are the other thing you will get? এট্রিয়াম ফর দ্য মিডল মিয়েটাস, তার মানে ম্যাক্সিলারি সাইনাস ওপেন করবে কোথায় বলেছিলাম, মিডল মিয়েটাস। ওকে, সো দিস ইজ দ্য এট্রিয়াম অফ মিডল মিয়েটাস and this is the inferior meatus. Okay, so remember these are the part you have to say the muscular attachment. Okay, now the anterior surface, already I told you কি কি মাসেল পেয়েছিস, ডিপ্রেসার সেপ্টাই কোথায় থাকবে, ইনসিসিভ ফসাতে থাকবে, ক্যানাইন ফসাতে কে থাকবে, দিস ওয়ান ইনসিসিভাস সুপিরিয়র, রাইট ইট ডাউন, ইনসিসিভাস সুপিরিয়র। আরেকটা মাসেল হচ্ছে অরবিকুলারি সরিস, পুরোটা থেকেই অরিজিন নেবে, অরবিকুলারি সরিস। ওকে, so these are the two muscle and above there is nasalis muscle. Nasalis muscle কোথায় থাকবে, nasal bone attach থাকবে nasalis muscle. Okay, and infraorbital nerve and vessels কোথা দিয়ে যা আসবে, infraorbital foramen দিয়ে। Okay, and the last one is levator labii superioris and along with levator labii superioris alkanasa. These are the muscle you will get. Okay, now coming the infratemporal surface. Okay, infratemporal surface এ কি পাবি, just the opening of the alveolar canal. Okay, opening of alveolar canal where 2 to 3 opening of the posterior superior alveolar nerve. Never forget the name. Okay, it is coming from backward, so it would be posterior, and it is superior alveolar nerve that is made for the upper jaw. Okay, আর ব্রাঞ্চটা যদি কি বলে, it is a branch of maxillary division of trigeminal nerve. Okay, now the infero-posterior part of maxillary tuberosity. So this is the infero-posterior part of the maxillary tuberosity, means inside you have to see towards the maxillary sinus. It will articulate with pyramidal process of palatine. Again PPP, but it is different. Pyramidal process of palatine. Okay. So this is about the infratemporal surface. Now coming to the orbital surface. Orbital surface এ একটাই মাসেল থাকে। Could you tell কোন মাসেল অ্যাটাচ থাকবে? Inferior oblique. Write it down. The orbital surface of maxilla, there is only one muscle attached, that is known as inferior oblique. Inferior oblique. Okay, and medial border has got lacrimal notch. So this lacrimal notch along with conchal crest, it will form the nasolacrimal groove. ঠিক আছে, so this is for the orbital surface. And another thing you have to say again, in the infraorbital foramen will come in relation. Okay, so this is about the orbital surface. Now to the nasal surface, this thing already I told. Okay, how the maxillary sinus has been reduced. What I said, uncinate process of ethmoid, then second one is arekta kon bone asbe superiorly lacrimal, uncinate process of ethmoid and lacrimal superiorly. Inferiorly ke asbe, inferior nasal concha, orbital plate of inferior nasal concha, and another one is medially ke asbe, PPP, that is perpendicular plate of palatine. Okay, so these are the three bones. See over here, this is very much important, MCQ আসতে পারে, ঠিক আছে। আরেকটা হচ্ছে যে if you see the hard palate, see already I told you in the base of the skull, this foramen has been formed just below the incisive fossa. This is also known as incisive foramen. Which thing will pass? একটা artery, একটা nerve. So one is greater palatine vessels and nasopalatine nerve. Write it down. Incisive foramen transmits the greater palatine vessels and nasopalatine nerve. Okay, আর এখানে প্যালেটে আর কি পাবে, হার্ড প্যালেটে, this is a part of maxilla, so you have to study, right? Which are the thing you will get? This groove is for, এটা কার জন্য আছে, for the palatine glands. Okay, if you see the superior aspect of oral cavity, it is not smooth, তাই তো, so there are numerous grooves, so these are made for palatine glands. Okay, so this is about the nasal surface. Now coming to the zygomatic process. Zygomatic process again has got কি process আছে, anterior, posterior and superior rough for articulation with zygomatic. So only one thing you have to know, which one is for the zygomatic. So which one is the for zygomatic? See this one. Which process you will have this rough area, that is for the zygomatic bone. Okay, so which suture it will form? সুচারটার কি নাম হবে? জাইগোমেটিকো ম্যাক্সিলারি সুচার। ঠিক আছে, এটা রাফ দেখতেই পাচ্ছিস, যেখানে তুই স্মুথ পাবি দ্যাট মিন্স অ্যাটাচমেন্ট ফর মাসেল অর টেন্ডন, ফ্রিকশন হবে না, কিন্তু বোন হলেই কি হবে, রাফ হবে। সো দিস এরিয়া ইজ ফর দি জাইগোমেটিক বোন। সো রাইট ইট ডাউন, the superior rough area for the articulation with zygomatic bone, which is forming the zygomatico-maxillary suture. Zygomatico-maxillary suture. Okay. Now frontal process. So already I told you frontal process যেটা আছে সেটা হচ্ছে which is the most projected and faces superiorly. It will articulate with frontal bone. Which part of frontal bone? Maxillary process of frontal bone. Write it down. The frontal process of maxillary will articulate with the maxillary process of frontal bone. Okay. Then crest will be giving attachment to যে crest আছে. So which one is the crest? So if you see the frontal process, এখানে একটা crest দেখতে পাচ্ছিস. Okay. So this crest is for attachment for orbicularis oculi, and another one is levator levi superioris salicanizai. Okay. So frontal crest there is attachment of two muscle. Orbicularis oculi কটা part আছে? How many parts are there? একটা orbital part আর একটা হচ্ছে palpebral part. Okay. And both nerve supply is different. Okay. So this is orbicularis oculi. Please make for short note or long question, very much important along with diagram. Okay, orbicularis oculi. Now coming to the alveolar process. So if you see the alveolar process, it is made for lots of sockets. So which are this one? কতগুলো socket থাকে বলতে পারবি একটা maxilla-তে? 8. একটাতে 8 থাকবে, একটাতে 8 থাকবে, 4 ভাগ 1/4 হবে। তুই if you count you will get 8। ঠিক আছে, তার মধ্যে কতগুলো বল? ইনসিসিভ হচ্ছে দুটো, তাই তো? ক্যানাইন হবে একটা, তারপর প্রিমোলার দুটো, আর মোলার হবে মোলার 3টে। ঠিক আছে, এর মধ্যে মোলারে কোন ইয়েটা ওপেন করে, কোন স্যালাইভারি গ্ল্যান্ড ওপেন করে মোলারে? The parotid duct. You have already studied parotid gland. Parotid duct opens into the opposite to the crown of upper second molar tooth. ঠিক আছে, opposite to the crown of upper second molar tooth. This is for the parotid gland. Okay. So last one is the palatine process. So already you know palatine process means you have to say about the hard palate. Okay. So already I told you it is forming how much the hard palate? 3/4. Okay. And which are the thing you will get? That is the greater palatine groove, greater palatine vessels, and nasopalatine nerve along with the palatine glands. Okay. So now coming to the clinical anatomy. So one by one I will discuss. Okay. Okay. So for ossification, write it down. Ossification, maxilla ossifies for one primary center for the body of maxilla during 6th week of intrauterine life. 6th week of intrauterine life. Okay, and has got two secondary center. One is for the alveolar process. Another one is for the palatine process. Okay, এখানে একটা ভীষণ ইম্পর্টেন্ট, when does maxillary sinus form? ওই যে maxillary sinus is reduced by so many bone, so it is forming one complete sinus, পুরো ক্যাভিটিটা ক্লোজ হচ্ছে কখন? ভীষণ ইম্পর্টেন্ট, 4th week of IU life. Write it down. Sorry, 4th month of IU life. Okay, write it down. Maxillary sinus forms during 4th month of IU life. Okay, so write it down. There may be short note about maxillary sinus. Maxilla থেকে অন্য কিছু আসবে না, maxillary sinus আসতে পারে। So এটার আরেকটা নাম কি? It is also known as antrum of high more. Okay, antrum of high more. So it has got one base. It is triangular in shape. Write it down. It is triangular in shape. It has got one base. Which is directed towards the nasal cavity, and apex is directed to the zygomatic process. Okay, এবার যেটা আসতে পারে about the length and breadth. Okay, length and width. So write it down. Length is about 1 inch. Length is about 1 inch. And the width is about 1.5 inch. So you have seen so many sinusitis, right? So many patients are suffering from sinusitis. But why we are concerned about maxillary sinus? Once the patient suffers from maxillary sinusitis, it is a chronic condition, very difficult to treat. Why? This may comes as explained why. Write it down. Why maxillary sinusitis is chronic? So just now I said, suppose any inflammation is formed on the maxillary air sinus. Okay, there is a situation of chronic cough. Okay, so what will happen? The fluid would be accumulated in the maxillary sinus. So from where it will drain? Apex দিয়ে তো drain হবে না, base দিয়ে drain হবে. কোথায় drain হবে তাহলে? To the nasal cavity. আর maxillary sinus কোথায় open করে বলেছি? Middle meatus. So the reason is, write it down. The antrum of maxillary sinus, the antrum of maxillary sinus is lower than the nasal cavity. এবং কতটা lower? 1.25 inch. Write it down. 1.25 inch. ঠিক আছে, তো যদি nasal cavity এর ওপেনিংটা উপরে থাকে, maxillary sinus এর ওপেনিংটা নিচে থাকে, তাহলে ড্রেন হবে? হবে না. Suppose this is the floor. So this is accumulated with fluid and the drainage system it is higher, so it won't drain. So this is the reason. Okay, so you have to explain, that's why maxillary sinusitis is chronic. Nasal cavity opening ta opore thake kotota? 1.25 inch. Okay, so another one is maxillary tumor. Write it down. Maxillary tumor, it will happen, if it will happen, maxillary sinus e hote pare, because that is the open space. So what will happen? It will break the orbital cavity. It will either go to the orbital cavity or to the oral cavity. Okay, দুটো হতে পারে. And the third one is very much important, that is known as maxillary fracture. Very common. Suppose anteriorly any blunt trauma by RT or anyhow, there would be fracture of maxilla. So there are 3 type of fracture. So these are known as Lefort fracture. So write it down. Fracture of maxilla is classified under Lefort classification. Lefort. Okay, Lefort classification. So there are 3 type. Okay, so if you see the picture, you could see. So প্রথমে first এ হচ্ছে Lefort 1. Okay, Lefort 1. So it will involve 42%. Okay, 42%. And where it does, it will involve, see, what is this? So it is involving only below the zygomatic process. So write it down. For Lefort 1, it is below the zygomatic process of maxilla. এটাও কিন্তু শর্ট নোট আসতে পারে, ভীষণ ইম্পর্টেন্ট. ওকে, দেন Lefort 2, if you see the Lefort 2, where does it involve? It is taking the alveolar process. This is the zygomatic process. Now it is also taking what? The frontal process. Okay, frontal process of maxilla. And the third one, very less. So that is also known as Lefort 3. So if it will involve, you are seeing the whole maxilla has been involved. Ar ki bone involve hocche bol? One is zygomatic, আর zygomatic হচ্ছে, this is whole maxilla, তাই তো? maxillar এটা হচ্ছে frontal process, এটা হচ্ছে তোর alveolar process, এটা হচ্ছে zygomatic process, তাই তো? আর কি বোন ইনভলভ হচ্ছে? এটা কি? nasal bone. Okay, so it will involve, write it down, Lefort 3 will involve whole maxilla, the whole maxilla along with the zygomatic and nasal. Okay, and posteriorly also some part of palatine. Okay, posteriorly also some part of palatine. And this fracture is also known as craniofacial disjunction. Write it down. এটা মানে কি? পুরো ক্রেনিয়ামটা আলাদা হয়ে যাচ্ছে, পুরো লোয়ার পার্ট অফ ফেস আলাদা হয়ে যাচ্ছে, তাই তো? So this is known as craniofacial disjunction. So Lefort 3 is also known as craniofacial disjunction. Okay, so this is all about maxilla. Okay, so main thing you have to know the clinical anatomy and maxillary sinus, very much important. Okay, and the part of maxilla, at least in Viva if examiner will ask, you have to tell which are the process. Okay, and this foramen I told infraorbital foramen. Okay, and another one is nasolacrimal groove. These two are important. Okay, so thank you.